My name is Oana Gelemanca. My activity includes working as oromaxillofacial surgery resident at Emergency Hospital in Craiova, and later in the afternoon continuing my private practice at WhIteKiss Clinic from Craiova. Our city Craiova is localized in the southwest of the country and is the sixth largest city from Romania, and it's also a university town. Just to share my video also. Here, I want to show you, unfortunately, I don't know if I can share the sound also. I want to show you a few shots from our clinic. WhIteKiss, it's a multidisciplinary clinic. We are 21 souls that put a lot of effort and pleasure into each case and everyday work. Besides the surgery department, we also serve all other specialties, ortho, perio, prosthodontics, and endodontics. We enjoy working with top technology like lasers, CAD/CAM, microscopes, CBCT scans, and we are trying to improve each day in new technologies and also in latest treatment techniques. I want to point out the obvious from the beginning of the presentation. All the cases that I will present belong to Dr. Gheorghita Mircea, who is a maxillofacial surgeon and consultant at the Department of Maxillofacial Surgery from Emergency Hospital of Craiova. We, of course, are a surgical team that plans, organizes, and executes the surgeries, but the mastermind that holds all the knowledge, of course, and surgical experience, surgical talent is Dr. Gheorghita Mircea. You can find many more interesting surgical cases from OMF pathology and oral rehabilitation on his Facebook and Instagram pages. This is OR, the OR where we realize our surgeries in general anesthesia. Actually, this photo, we took it at the intervention that we did this morning, an upper maxilla individualized implant. I think in 2021, individualized implants are not a novelty subject anymore, especially when we passed through 2020 pandemic and everybody had plenty of time for individual study and worldwide webinars that made us grow rich in our knowledges. Subperiosteal implants date back from the 1940s, and since then they came along with a lot of changes. Science learns from past science mistakes. So today we have an improved device that promises to be one of the best solutions for severe atrophic bone. We all know the struggle when we have a case of severe bone atrophy to find solution for fixed rehabilitations, and the motivation kicks in even stronger when we are dealing with young or very young patients in this situation. Depending on many factors as patient age, class of atrophy, systemic health status, we may opt for different rehabilitation techniques. We either can go building bone in Curie technique with autologous bone or other forms of bone augmentation, sinus graft, lateral or crestal approach, or we can plan graftless rehabilitation by using Olonics techniques, hybrid zygoma or quad zygoma, and of course nowadays with the help of specialized data acquisitions, technique combined with CAD/CAM technology and laser 3D printing, we can also use individualized implants. So we will begin the presentation with a bimaxillary case of individual to handle otherwise. Patient in his 40s presented in the clinic with a severe periodontal disease, accusing teeth mobility and mastication difficulties, and of course physiognomical complaints. Besides the severe atrophy, the case turns even more challenging considering the particularities of it, the crossbite occlusion and a vicious consolidated fracture, all fracture in the left body of mandible. The patient was a victim of a car accident. Through section of the CBCT, we can observe the knife edge alveolar bone. And also it's the same situation on the maxilla and on the mandible. There's an old indentation. Here we have the digital planning of the implant. We take in consideration a lot of things when planning an implant. In this picture, we can observe that we have 4 connectors for each implant, and to plan the prosthetic part, also we are guiding the abutments and the angulation, the direction of the abutments. Here we have the full planning of the individualized implant and prosthetic restoration. Each implant, as I said, presents 4 connectors, and in this step of the planning, we decide the angulation of the connectors, which can be evaluated through the abutments, the anchorage of the body of the implant. It's not casual, it respects the champion lines for the mandibular anchorage, and for the maxilla, the zygomatic canine pillars and nasal spine for the upper maxilla. Both maxillaries were done in one stage surgery under general anesthesia. This case, we had the chance of making a comparison between working with the standard acrylic guide that comes with the implant and the titanium guide. The titanium guide obviously is much thinner and easy to insert under the flap, easier to work with unlike the acrylic guide, which is bulkier, but the downside is that the titanium guide is extra cost. Here we can see the fitting of the implant on the models. We carefully check for adaptation before placing the implants intraorally on the bone. The implants come with these technical files that guides us in screws preparation, direction, diameter, length, color, and position in which to be inserted. The producer offers emergency screws in case that one of the screws has low stability. Also, then when there is a large number of screws, the file even contains a map of the screws to find them easier in the box. This way, there is a very low risk of mistake if you pay attention to all the details. Of course, intraorally, it is difficult to shot a wide angle of the implant bone adaptation, but it's nice to make a comparison between the both of them. Left and right side. On the right side, we have the healing caps over the multi-unit abutments. On the left side, only the abutments uncovered. And this is the final closure of the wound for the mandible. Here we have the upper maxilla implant, also a comparison between model implant adaptation and intraorally. In some cases, the bone atrophy is so severe that while creating the channels for the multi-units to sit below the bone crest level, you can reach till the Schneiderian membrane. In this picture, we can see here that one of the holes remained empty because one of the screws lost his stability. But as I said, we have emergency screws that either have a bigger diameter or a bigger length. Here we have the final closure for the upper maxilla. We had plenty of soft tissue, keratinized soft tissue in this case. This is the immediate post-op OPG for a full view, but next I will show you the sectional view. We like to check each section of the fitting on the implant on the bone. This is a large volume CBCT made to check also the maxilla and mandible. It's interesting to gather all planning information and post-op results so you can get a real comparison between planning and reality, as you can see in this picture. Here we have 1 month healing for the upper maxilla As I said, even in the healing, after healing period, we still have a thick keratinized tissue around the abutments, which is what we want at every case. Here is the healing for the mandible. And a short before and after with the rehabilitation. One can appreciate the transition from a crossbite occlusion to an almost normal one. And a very nice transformation of the smile. This is the next case. This case was done in another department. So the documentation of the case is not the best given the fact that we cannot apply our protocol, but the case went out very well, and it's a particular case for the fact that we have a rare case of fractured zygomatic implants. So what decision should be made in this kind of situation? The implant was inserted 4 years ago by another clinician. And the cause, most probably the cause of the failure was the over-oblique insertion of the zygomatic implants and the occlusal stress. Considering the fact that the bone around the two zygomatic implants did not develop any peri-implantitis process, and the difficulty and risk associated with the explantation, we decided to leave the implant in place and plant the individual implant considering that. Here we can observe the two zygomatic implants that are fractured. And the individualized implant, which, by the way, it's a pure 5th grade titanium with a hybrid surface. The inner surface that comes in contact with the bone is a treated SLA surface, and the outer surface that is polished is soft tissue friendly. On the left side of the implant, you can see there's an asymmetry in comparison with the right side. It's because the design of the implant considered the zygomatic implants. The screws were planned to avoid the zygomatic implants. Here is the outer surface of the implant. And here we have a close-up to the screws. The screws are also SLA treated surface titanium grade 5th grade. The screws have two parts, a treated surface that goes into the bone and also integrates, and a non-treated polished surface that goes outside the bone into the implant. Here we have the implant, and we can see both zygomatic implants. And the final closure of the wound. Next, we have 1 month healing. We can see that we have a small defect on one of the connectors. And here is 2 month healings. So we decided to proceed for a small soft tissue grafting. So for us, the safest and fastest way to harvest a graft is from tuberosity with a soft tissue punch. There we can find a thick connective tissue. And after we harvest the connective tissue plug, that's how I like to call it. I think it's a suggestive name for how it looks. After we harvest it, we make it thinner and longer. We split it like a harmonica and stretch it on the side of the vestibuloplasty like an onlay graft. Just suture it with 6-0 polypropylene. And the result, we get a less rigidity of the donor site and a nice FGG graft. We have to keep in mind that although with individualized implants, we get to treat the hard tissue, and we don't stress anymore about bone volume in which to insert implants. The soft tissue, it's still an issue that we have to take in consideration and manage to have it the right quality and quantity, and also a right prosthetic on it. Last but not least, we want to present you a case in which we take very much pride. It's not a bone atrophy case, it goes much beyond that, and you will see in the next slides. This is a patient with a long medical history. She suffers from a genetic condition, Turner syndrome, and was discovered with central cell granuloma 7 years ago. After the resection of the tumor, she underwent several attempts of reconstruction with an iliac crest graft and a free fibula flap. Both grafts failed, and the patient remained with this primary reconstruction plate that you see in the next slides that didn't meet any functional or aesthetic expectations. I think it should be a video here. Yes. This is a sectional view on the mandible and the primary reconstruction plate. Well, the patient gathered all her strengths and hopes, and she came into our office seeking for a treatment option that can restore her physiognomy and functionality. She couldn't eat. Of course, she was very unpleasant by her looks. The patient was not willing to have another invasive surgery, so this time we had to put all our efforts into a last try. So we planned an implant that was made to rebuild the interforaminal arch and also has 4 connectors like any other standard individual implants for a future fixed restoration. The design of the implant considered many other aspects like muscle insertions. In the body of the implant were incorporated void spaces and small holes for the muscle to be attached through sutures. The little holes are for platysmal attachment and the larger ones are for the anterior bellies of the digastric muscle. We used the cervical approach. After dissection of the anatomical planes, we discovered the primary reconstruction plate and removed it. This is the guide. This is the actual implant that acts like a guide for the vertical positioning of the mandible ramus. And here is the implant in place. Here is a close-up to the tight closure of the space between the masseter muscle and the pterygoid. A close-up to the implant bone fitting on the right side. Here we can see the anterior bellies of the digastric that are skeletonized. And a more wider view of the implant. There are 4 connectors that emerge intraoral beneath the gingival mucosa. They are covered with flat healing scabs because they were left buried under the soft tissue for now. In this intervention, we didn't touch any of the endooral mucosa. Everything was done through the cervical approach. Another interesting thing about this case, because if you usually cut and approach the bone intraorally and discover everything inside the mouth. This time we worked beneath it and we didn't even touch the soft tissue. Here we can see the submental artery. Also the suturing of the platysma to the small holes of the implant. And another CBCT, a sectional view. I think at this case and at every other case, the bone, the adaptation between implant and bone was perfect. And now we have an early post-op result. The after picture was taken in the hospital. Today is post-op. And now we have a result at 1 month post-op. In the future, the challenge of this case will be to work with the soft tissue because there's a lot of mobile mucosa around the connectors of the implant inside the mouth. Here is the result at 1 month post-op. You can see the reconstruction of the chin. We planned to push it up and forward to rebuild the anatomy. And this is the lateral view. I think this is one of the greatest cases that we have managed to come through. The patient is very, very satisfied, and we are also, and all with the help of Bone Easy. So thank you all for your attention, and thank you, Dr. Rui Coelho, for invitation. I hope you enjoyed our presentation and our cases. Thank you very much.
Thank you so much, Dr. Oana. We did enjoy your presentation. Now I would like, we're going to move to our last but not least speaker,